Well, let me welcome all of you to the third in the National Academy of Social Insurance's series of state roadshows focused on universal family care. And today our specific topic is strengthening the state of Minnesota's care infrastructure, looking at pathways to achieve universal family care. Last fall, we hosted in-person forums in Salem, Oregon, and San Francisco, California, and we have virtual forums planned for the rest of this year in Illinois, California, and Michigan. We were hoping we could do this one in person. Unfortunately, events have not permitted that, but we hope that you find this virtual experience meaningful. We'll be looking at the implications of universal family care for distinct stakeholders: family caregivers, those involved in the direct care workforce itself, older people as one group that is in need of care, and people with disabilities here in the state of Minnesota. Now, last year, our Academy joined forces with Caring Across Generations in releasing a comprehensive study of viable approaches for states interested in pursuing universal child care, paid family and medical leave, and long-term services and supports, or what we call the Universal Family Care Program, that was based on the findings of an academic study panel, an academy study panel, that was made up of 30 interdisciplinary experts. The study panel deliberated over a period of more than a year in coming up with a rather robust set of options for states to consider to address one or more of these caregiving challenges. When we issued that report, we couldn't imagine how important it would be in today's world of COVID-19. The pandemic is highlighting both the inadequacy and the inequality in our country's care infrastructure. Right now, what we really have is a patchwork of programs at state and federal levels. They help some low and middle income families pay some of the costs of early child care and education for some long-term services and supports, and taking some time off to care for a loved one. But I think all of us can agree readily, these programs are chronically underfunded and really inaccessible to many people who are in desperate need of these services. The COVID-19 federal legislation does provide some relief for millions of Americans during this time of crisis and catastrophe, but significant gaps remain. The challenge of balancing work, health, and family responsibilities we know will continue after the current pandemic, and let's hope there is an after the current pandemic for workers across our country. When we use the term universal family care, what do we mean? This concept offers an integrated, holistic, social insurance-based approach to family care. And it's an approach designed to strengthen our care infrastructure to meet families' changing needs over time. The focus, of course, is that these needs change. We can't afford a static approach. It must reflect reality. And during this time of crisis, we know that communities are examining the gaps in the care infrastructure and exploring bold, and I want to emphasize the word bold, policy approaches to increase both the quality and the accessibility of care for individuals and families in need of it. Now, today, we are not able to closed caption our discussion, but for the hearing impaired, there will be closed caption recording of today's session available on the Academy's website, nasi.org, later this week. And we welcome your suggestions for making future virtual meetings fully accessible. A couple of housekeeping notes before I turn it over to Josie Calipini of Caring Across Generations. We really relish your participation in today's dialogue using the tools on your Zoom screen. For those of you who are Zoom veterans, you know how this works. Two ways to participate. There's a chat box or a Q&A box. You can type comments in the chat box and use the Q&A box for specific questions for our speakers. And both boxes are available at the bottom of your screen. We also welcome questions via email after you've watched the closed caption recording of today's session, which will be on our website later this week. The chat feature is intended to enable all of the audience members to converse with each other. So if you're going to use the chat feature, make sure that recipients are all panelists and attendees. The default option is all panelists. So we've got to switch to all panelists and attendees manually to ensure that every participant will see your comments. Otherwise, use the Q&A section to address questions to our panelists. At the end of the webinar, we're going to try to continue the discussion on our website. The caregiving research section of the Academy's website contains relevant work compiled by Academy members and staff, including the Universal Care Report that is the base of this webinar. So without further delay, I'm hoping that Josie Calapini has joined us. There you are, Josie. Good to see you as always. We are very thrilled with our ongoing partnership with Caring Across Generations. Josie directs policy and federal affairs for Caring Across Generations. So Josie, let me turn it over to you.
Thanks, Bill. Great to be with you and with everyone today, having this exciting conversation in the midst of the moment that we're in. I think great opportunity to reimagine what the future looks like. As Bill said, my name is Josie Calapini. I'm the Director of Policy and Federal Affairs for Caring Across Generations. Caring Across Generations is a national organization working to change the way we value care and caregiving in this country, with a focus on ensuring that our system is accessible, affordable, comprehensive, and dignified. Over the course of our existence, we learned the key pressure points that people caring for their families are experiencing and people who are trying to access the care system are experiencing. We hear of parents who are financially two-stepping between the cost of childcare and the costs associated with caring for their favorite aging uncle. We hear of adult children sneaking away from work to get a sick or disabled parent to an appointment. The truth is that our current system isn't set up for our current family and economic dynamics. We asked ourselves the question, what do families really need? If we could reimagine, if we could rebuild the care infrastructure today, taking into account history and future projections, what would we and our families build? And that's how universal family care was conceptualized. Universal family care brings into one point of access childcare, long-term community-based services and supports, and workforce interventions like paid leave, care workforce recruitment and retention, and increased wages, so that the care infrastructure works in an interconnected way for families. This event today continues the work to support a new vision on how we build the care infrastructure our most vulnerable families deserve. Fully funded, integrated, and family-centered. We can come out of these dual crises stronger, healthier, and more equitable. Minnesota is a key state in the national fight for improved care and support. We know that working families are struggling to make ends meet, even before our current health and economic crises, and care crises were too often the piece that put them over the edge. Our current care infrastructure is a siloed patchwork of programs, which often require many hoops and hurdles to gain access. The COVID-19 crisis has made it clear that our care issues are deeply interconnected and that we don't have the infrastructure necessary currently to change that. We can and must change that as we continue to deal with this crisis and think about what a recovery looks like. We can't return to the status quo, and Minnesota is at a crossroads where an opportunity exists to reimagine the future for all Minnesotans. Caring Across Generations has been working with Take Action Minnesota and the Academy for many years. It is very exciting to be bringing these two partners together for this powerful event that will change the course of our future. It's my pleasure to introduce Eliane, the Executive Director of Take Action Minnesota. She's been working for over 15 years, campaigning for racial, economic, and social justice. Eliane, take it away.
Thank you, Josie and Bill. It's good to be with you all this afternoon. Very grateful for the leadership and partnership with the National Academy of Social Insurance and Caring Across Generations, and excited to have this conversation with you all today. I'm going to briefly give a slight overview of the conversation we're going to have. Bill and Josie did such a good job. I won't have to say too much, and then we'll dive into hearing from experts, local elected officials, folks on the front lines here in the state of Minnesota to really explore why, but more importantly, how we respond to the multiple overlapping crises we're facing in our state and in our country, but also the solutions that we can move. And we know that even before the COVID pandemic, we were facing a crisis of care in our state. And we, working with our partners, really began to explore what does it look like to not move a siloed approach to solving these overlapping and integrated crises, but what if we moved a comprehensive integrated solution that's going to have a better chance of actually meeting the challenges our folks are facing and actually solving the problems and taking care of our families, no matter their stage of life and their financial situation. And so very excited to explore a little bit of the why with you all today, but more importantly, the how, because we know that we need to solve these problems and increasingly we know how to do it. And so focusing on that today will be an important piece of our conversation. So to start us off, we're going to hear from a champion elected official in our state, Representative Jennifer Schultz, and then from two researchers who have been really leading the charge on figuring out the how of universal family care infrastructure. So I'm going to pass it now to Representative Jennifer Schultz. She is a rep in the Minnesota House of Representatives. She serves on the Health and Human Services Committee and on the State Government Finance Committee, and was also on the Governor's Healthcare Finance Task Force. So she knows this issue inside and out and has been a real champion to advance meaningful care solutions for Minnesotans. And I'll pass it to you, Representative.
Well, thank you. So first of all, I want to thank all of the organizations that have organized this webinar and trainings and symposiums in the past, including hearing, I'm trying to pull up my, here we go. Caring Across Generations, the National Academy of Social Insurance, and Take Action Minnesota. So I'm currently chairing the long-term care division. So a lot of my comments are going to talk about the long-term care piece of this universal package. But I do know that early education and child care, paid family and medical leave, and access to long-term care, they're all vital programs that will help families thrive, not just in Minnesota, but across the country. All of these programs would have helped my mother as she struggled to care for me and my sister, and now as she faces aging in place. In Minnesota, we've passed legislation in the House funding childcare and early education and paid family leave. We've introduced legislation to create a public trust fund for long-term services and support, similar to the Washington state model. But unfortunately, many of these popular policies did not pass the Senate and therefore are not being implemented. So in Minnesota, we have significant work to do, and I'm excited to work with you all to get these policies implemented and to experiment in the state of Minnesota. So we have many crises to deal with, not just the pandemic and civil unrest. We want to work on social justice and equity issues, but another crisis is coming, and one that we have had very little discussion in our legislative body. And that's the aging of the population and the expense of long-term care. So by 2030, roughly 22%, almost 1/4 of the Minnesota population will be 65 years of age or older. And the oldest baby boomers, I believe, will start turning 80 soon in a few years. So this is why we need to act soon. Today, the majority of long-term services and support is paid for through the Medicaid program at tremendous and growing expense to state budgets. The average annual cost for caring for older adults in Medicaid is about $40,000 in Minnesota. And 93% of the population 65 years of age and older do not have long-term care insurance and typically deplete their savings to become eligible for Medicaid. And those with private long-term care insurance are experiencing significant premium increases from anywhere between 20 and 50%. So long-term care related Medicaid costs are growing at really an unsustainable pace, with more than half covering long-term care. So without significant change and reforms and working towards progressive policies, long-term care expenses alone will bankrupt households and governments. So in January of 2019, the University of Minnesota School of Public Health, with assistance from Joe Gogler, Own Your Future program in Minnesota, AERP, they held a forum on long-term care financing, and many of your organizations were there, represented and presenting, along with the Minnesota Department of Commerce, Mark Cohen, DHS, MDH, the Washington State Department of Social and Health Services, state legislators, and others gave very insightful presentations and fielded questions. It was an excellent forum for state legislators to hear about long-term care financing challenges, to learn about all of the state initiatives in Washington, Hawaii, and Maine, and to learn about potential policy options. So one key takeaway from the forum, for me at least, was that states really need to continue experimenting with new models of standalone financing programs that are, 1, affordable, 2, simple, and 3, stable. So we can learn, I'm hoping, a great deal from the various state approaches, and I'm very grateful for all the work you've been doing across the country, and I look forward to participating in the future. So in summary, we basically need every state to explore public-private partnerships in the long-term care financing area, and we need ultimately to find a universal family care option for Minnesota that everyone pays into and everyone benefits. And I'm glad to be here today to learn from our presenters, and I want to again thank the hosts and the organizations for conducting this webinar and for the invitation to participate. Thank you.
Thank you, Representative. What a great way to kick us off, giving a little bit of background of what's already, the groundwork that's already been laid in our state and what the path forward looks like. And so to dive a little bit more into what it would look like to build out a comprehensive universal family care infrastructure, we're going to hear from 2 researchers and experts on the issue. First, we'll hear from Marcy Ibarra, Associate Professor at the University of Chicago School of Social Service Administration, and then Mark Cohen, the Co-Director of Leading Age LTSS Center at UMass Boston. Go ahead, Marcy.
Good morning, everyone, or I'm sorry, afternoon, depending on what time zone you're in. I'm Marcy Barr. I'm an associate professor at the University of Chicago School of Social Service Administration. I'd like to first thank the National Academy of Social Insurance, Take Action for Minnesota, and Caring Across Generations for inviting me to participate in this webinar, and to all of our attendees who are here and joining us. So I thought, next slide, please. So I wanted to give a little bit of background before we started just on moms and work in the United States and the changes over time. These trends, sneak previews, suggest that we are already behind the curve in addressing this issue. So it's nice to see a lot of championing of paid family leave and long-term care and early childhood education, because it's quite clear that we need them. I'm going to spend a little bit of time on current programs, so unpaid leave provisions. Then I'm going to discuss paid family leave provisions that are in place, and early child care and education, and then bringing it all together at the end. Next slide, please. And the following slide, please. Okay, so this chart shows mothers and work over time, and it reflects the growth of women in work from 1975 to 2015. And things haven't dramatically changed, except with, of course, the pandemic. We've seen a huge cliff effect of the pandemic on everyone's work, including women's work. So I didn't include it here, but just know it's been severe. And this is by age of the women's youngest child, because oftentimes in the field, we hear things about, women with young children tend not to work as much. And by young children, we typically mean 3 years or younger, 2 years or younger, or 1 year or younger. And what this chart is demonstrating is that it's common for women with children, minor children of any age, to be in the workforce, and that this has substantially increased over time for all women, irrespective of how young their children are. Probably, I would say, the most important point to highlight is that even women who have children 3 years or younger, which would be the pink line, have dramatically increased their labor force participation, with some of that bump coming, if you look at the vertical line of welfare reform that overhauled the cash welfare safety net and imposed work requirements on women, even those with very young children, plays a small part in that role. But really, I just wanted to get us all on the same page with the fact that most mothers work irrespective of their child's age currently in the US. Next slide, please. And this is also highlighting new mothers and their work by labor force participation. And so what we see here is about 2/3 of women who have a child, within a year of having that child, they're back to work. They're already working. 2/3 of women in the labor force with children who are under 12 months. Next slide, please. And education levels. So there's also a narrative around women with more education tend to be the ones who are going to work or having to work, and that less educated women, so those who have maybe some college but no degree or high school only or less than high school, aren't going back or don't comprise a large share of women who are working, and that's just not true. About 2/3 of women with a child who are 1 year or younger are working in their first year, and 36% of those in the labor force with a recent birth are also unmarried. And so this suggests dual factors that might hinder work among women with less education, being that they're on their own and that they don't have a college degree. Next slide, please. And new mothers and poverty. So some of the response to the previous slide might be, well, then families with a mother who is working should be okay because they're working and bringing in income that way. And it turns out that about 2/3 of women with a child 1 year or younger, about half of women are below the poverty line, or they're lower income, meaning they're at 200% or below of the poverty line. So overall, the takeaway being that most mothers are in the labor force within the child's first year of life. Among those who are going back to work, we have a large share that are less educated with less than a college diploma, and unfortunately a large share that even when they're working and have a child younger than a year old, that a substantial minority are also low income or low wage workers, suggesting that they're struggling with family household economic demands early in the child's life. Next slide, please. And so does that change relative to women who are married versus those who are not? And there's all kinds of reasons we would expect married couples to have resources that a single parent doesn't have. The first and primary one being dual incomes. Not always the case, but it's not uncommon for it to be the case. So we look at this slide of mothers and work by marital status. What we see is that labor force participation between married and unmarried mothers is actually not that different. Although single mothers tend to work at a slightly higher rate with younger kids. Next slide, please. So what do we provide in the US? I'm going to begin with the unpaid provisions of the Family and Medical Leave Act of 1993. Most of us, I think, probably already know a lot of this, so I'm going to focus on the areas of FMLA that I think some folks might not know. It only applies to workers who meet a particular criteria. So covered worker is a public or private sector employee. They have to work at a firm with 50 or more employees, have to work in 20 or more work weeks in the current or preceding calendar, and eligible employees who qualify are entitled to take FMLA. They have to work for a covered employee, have worked for the employer at least for 12 months, and have at least 1,250 hours of service for the employer in the 12 months preceding the request for leave. And so for those who qualify, FMLA can work out great because it offers a job protection strategy. Unfortunately, about half of low-wage workers do not qualify because of those requirements, meaning that if they needed to take leave, that wouldn't necessarily come with a job protection for folks who actually meet the requirements of FMLA. Next slide, please. So next, let's talk about paid family leave. 5 states currently have paid family leave in place, plus DC, and there are 3 other states, Massachusetts, Connecticut, and Oregon, who will be rolling out their programs in the next several years. I think, of course, California's began their rollout in 2004, and we can see this trajectory as a major win for advocates of family and work policies that are supportive of parents and children. So the programs definitely vary in benefit provisions. So for instance, requiring different earnings and hourly requirements to the length of maximum benefits. Despite that, they share some common goals, although the benefit amounts might be different. And so what they offer thus far have been paid time off due to your own sickness, yourself, spouse, or family member's illness, or bonding with an infant or an adopted foster child. Some of the key policy levers are wage replacement for sanctioned leaves. The replacement rates vary across states pretty dramatically, with early adopters such as California starting out at a 55% wage replacement rate, and now they're up to almost 70%. It's gotten more generous over time. And then the last entity to roll out paid family leave, being Washington, DC, actually has a pretty generous model, particularly those who are low-wage workers, in which low-wage workers can have 90% of their wages replaced. Leaves so far to date run from somewhere between 4 to 12 weeks, depending on what type of leave you're taking it for, as well as the state that you reside in. In states with temporary disability insurance, like California, New York, New Jersey, in those states, families can couple paid family leave with temporary disability insurance. And so when we say paid family leave in a state might run 4 to 12 weeks, if there's also a temporary disability insurance policy in place, they may be eligible for other benefits that they can then merge with paid family leave benefits. In some state paid family leave programs actually offer job protection. And this is turning out after, we're 15 years in, 17 now, almost 20, of examining California's paid family leave program, which originally didn't come with a job protection. There's lots of evidence, emerging evidence, I should say, and studies being conducted in which job protection is critical for particularly women who've had babies and being able to return to their old employer. This, of course, contributes to job continuity, less turnover, less of a penalty on wages for moms because they're continuing to work. Yet it's still not the majority of states with paid family leave programs that offer some kind of job protection. What about, next slide, please. What about employer provided leave? And we get this question a lot. Well, if states are going to come in and offer paid family leave, will that crowd out what employers are offering? So here in the US, it's somewhere between 12 and 13%. This slide says 12%. It's about right. I think it might be about 13 now. Receive any form of paid family leave from their employer. Next slide, please. So even when we consider other sources of paid leave, which is what this slide shows from the Bureau of Labor and Statistics, we do see an increase of workers with access to formal paid leave, but it's now at about 11%. Versus 2% of what it was 20 years ago. And then of course you see all of the other forms of paid leave that are sometimes offered by employers, such as paid holidays, paid vacations, personal leave, PTO time, things of that nature. And if you look at studies that are examining employer provided leave, what you see are folks are using a patchwork system in which it's much more common to piece together paid holidays, vacation time, and things of that nature than it is for a worker to receive formal paid leave from their employer. And so all of that is to say, we have very little evidence across states that implementing a paid family and medical leave program in a state necessarily reduces anything that's offered by employers. Number one, because they really weren't offering paid maternity or paternity leave at high rates. And the second is that we would expect some of these patchwork or patching together of other paid leave holidays or vacations to decline once a state had implemented a paid family leave and medical model. Next slide, please. So now I'm going to transition to early childhood care and education in the US. And I think that one thing that is a common thread throughout all the programs in the US is the way that we have siloed them. And early childhood education and care is no different from that. And I think this is what Bill had mentioned earlier on, was the cost of families having to go to multiple programs to receive benefits is very real, and early childhood education and care is perhaps an example of this. In the US, we have a host of private and public options. Some of the most commonly known are, of course, Head Start, the Child Care Development Fund, colloquially referred to as child care subsidies, when the government provides families, or I should say the provider, with resources for care to offset the cost for the individual family. Some states and locales have went to public preschool, but this is by no means a federal policy. It's states choosing to take this up. We have something like the child care tax credit, which is invisible through our tax code. And then, of course, we have folks who are paying out of pocket when none of the above either are suitable for them, even though they are eligible, or because it doesn't exist in their area. And an occasionally very small percentage of workers have some kind of employer subsidized. Even if it is employer subsidized, it's typically for a very small amount rather than a larger portion of what care actually costs. And so the patchwork system we've created in the US to address early childhood care and education is funneled through these various sources of public and private supports. And so what you can imagine is, if you are a family who's seeking assistance on care, all of these options might be available to you, and you might have to knock on all of those doors. And so one example would be childcare subsidies, in which in many states, there's a finite number of slots for those. So let's say a state has 100 slots, but they have 200 families who are eligible. 100 of those families will receive a subsidy, and then the other 100 would likely go on a waiting list, so their needs weren't taken care of immediately. That's typically done having immediate childcare needs met when you're paying out of pocket. Otherwise, it takes time to find a program, get accepted, hopefully you're eligible, all the things around that. Next slide, please. And then for early childhood education and care, the challenges are a little bit different. So for among those who can access care in the US, for child care subsidy policy, Head Start, anything that's geared towards lower income families, we've had this ongoing debate for the last 20 years about quality versus quantity, meaning that we are very invested in all children receiving high quality early intervention so that they're prepared for kindergarten and school more generally. And this is a tension with what families actually need, especially families who might work non-standard hours, might not have family who live around them, may not have transportation. And it's although they'd like their child to be in a highly rated child care center, it doesn't work out for a variety of reasons. It could be that they weren't able to access the program or get support from child care subsidies. It could also be that the hours of a facility do not align with the hours that the family needs. And then there's some preference for more informal care when children are 2 years or younger. So we have a host of things going on in terms of why families choose to use ECCE or not currently in the US, but certainly one of them is that our capacity to serve, we have not expanded it dramatically, while families' capacity given women being in the labor force in real substantial ways has dramatically increased. Next slide, please. And then finally, for early childhood education, it coincides with some of the things I just mentioned, which was it can play a major role in the stability of care for the child, and that means good, high quality educational interventions. This can also mean what stability of work looks like for families, right? If families have stable care, they are certainly more likely to have stable jobs, less turnover, improved work and earnings and income. We know when families access formal quality care that we see improvements in children's developmental outcomes, including some health outcomes. So the big takeaway for me from the ECE literature is that we have a system that isn't designed for everybody or isn't easy access for everyone. It's desperately needed, and when it works really well for families' work, for kids' care, and for longer term outcomes. And therefore, it's certainly a system we would want to see more families be able to access and use. Next slide, please. So why should we care? Big reasons I think of is it raises questions about what are our responsibility from a government perspective, from an employer perspective, and from an employee perspective. What is this responsibility in an era of working women with very young children to support time off for caregiving? In my presentation, I'm talking about it directly around the time of a birth, and then for children who are 0 to 6 and in most in need of early childhood education and care. A lot of issues related to equity. Who gets to access these programs, who will qualify for them, who's able to use them consistently. Although we know from paid family leave research that women who are lower income workers have tended to see the largest gains in more women taking leave, taking longer leaves, and having better outcomes. Issues related to short and long-term work and income instability. If we don't have good measures for providing care to families across the whole spectrum of their life, from the time a child is born, unfortunately, until the time we take care of our parents, that it's a continuation rather than these buckets of tasks or people that we have to take care of. That caregiving is going on all of the time, and they can contribute to improving long-term work and income stability outcomes for families if they're done well and made easily accessible. And I think that's my last slide. The one thing I did want to note before we move on is that, of course, in the era of COVID-19, it makes all of this much more critical, and it also adds layers of complexity, particularly in the early childhood care and education world, where we have the capacity of care has dramatically shrank due to social distancing and states closing down, and that with the, it seems to be proliferation of movement towards opening the economy, although that's uneven across states, what we might expect to see is demand outpacing capacity again, because we can't get the early childhood care workforce up and running prior to states opening up. And so that's kind of a long way of saying that the pandemic makes these things even more critical. It might also offer an opportunity to get these things taken seriously on the policy tables, and that if we can design systems in which, if we're caregiving across our life course, that we could access one system that we access across our life course to provide caregiving needs and responsibilities that would likely dramatically alter the time and costs of families applying and finding information on them, making their lives a lot easier, and accessing care for multiple caregiving responsibilities they'll engage in over the life course. Thank you. And I think next is my colleague, Mark Cohen, who will talk about long-term care.
And Mark, before you get started, there was a quick question that came in, Marcy, asking, does any of the FMLA programs apply to, quote, elder care, end quote, issues?
I'm sorry, could you repeat that?
The question came in asking, does any of the FMLA programs apply to elder care issues?
It could in the context if it was a family member and it was a qualifying sickness or illness, that FMLA is for you, your spouse, and your immediate family. But it's unpaid, I think, is the most critical piece of it, is even if you do qualify, it offers job protection, but no financial support if you take it.
Thank you, Marcy. All right, take it away, Mark.
Thanks. Hi, everybody. It's great to see everybody. Thanks for the opportunity to present today. I applaud the National Academy of Social Insurance, Caring Across Generations, and Take Action Minnesota for sponsoring this event. could I have the first slide or the next slide? There we go. Actually, even before I get into this first slide, you know, I was born and raised in Minnesota, St. Louis Park to be exact. And so it's so great to be virtually back with everyone. And I say virtually back because I don't miss the very unvirtual, real Minnesota mosquitoes. I remember those well and I shudder when I think about them. Today, I want to talk about a number of issues. One is I want to just describe very briefly the long-term service and supports financing challenges and solutions. And two, to describe universal family care, which brings together what Marcy spoke about and what I'm going to speak about into one holistic system. Could I have the next slide, please? So what's the case for action? Of the adult population reaching age 65, roughly half will have a significant LTSS, long-term services and supports needs. And for those who actually need to pay for care, average costs can exceed $250,000. Yet Americans are woefully unprepared to pay for their own care, should they need it. And the capacity of family caregivers who provide the bulk of care for individuals in need is diminishing. Private long-term care insurance is now out of the financial reach of most middle-income individuals. And the largest public payer of care, the Medicaid program, which, as was mentioned, comprises a sizable and growing part of state budgets, is under severe stress. So this is only worsening in light of the increasing health demands brought on by COVID-19. And we see what's happened to the elder care sector in particular, as well as the economic upheaval resulting from the pandemic. So there really is a need for a solution to address a very inadequately financed and underfunded LTSS service system and workforce. Just a few statistics to further make the point. Think about this. Over the next 30 years, the population over age 85 is projected to increase by over 200%. The population under age 65 is only going to grow by about 12%. So this has big implications for caregivers. Not surprisingly, there's a projected decline in the caregiving population ratio of 7 caregivers for every 1 elder to only 3 caregivers for every 1 elder over the next 2 to 3 decades. And states are left holding the bag. As I mentioned, LTSS represents 30 to 40% of state Medicaid budgets. It's growing rapidly, and it's competing with other budget priorities. As families reduce labor market participation to care for loved ones, economic growth suffers, and unmet LTSS needs drive up medical costs and harm quality of life for people with disabilities. Could I have the next slide, please? This slide talks about how a universal social insurance program for long-term services and supports could support and strengthen families. The most important point that I want to make, that's actually not written on this slide, is that LTSS is an insurable risk. You have a small probability of a potentially catastrophic event occurring for a relatively small group of people. And it's difficult to know in advance whether you might be one of those people who becomes dependent on someone else to help you with your activities of daily living. For that reason, and for many others, it makes sense to move the system away from a social safety net welfare approach toward an insurance basis. And some of the reasons are put forward here. And I'm going to just talk about what some of those are very briefly. If you look at the bottom of this slide where it shows stakeholders who can benefit. So if you had a social insurance program for LTSS, you would be allowing families to keep loved ones at home, providing peace of mind regarding LTSS needs, and reducing out-of-pocket expenses. You'd be enabling seniors to age in place, which is what they want to do. You'd be supporting people with disabilities to live in the community for as long as possible. You'll be bolstering the care economy by infusing new funding that would spur its growth. And you'd be enabling workers who are family caregivers to work full-time and pursue careers. In terms of the state, it would help to reduce Medicaid LTSS spending, and it would stimulate economic growth by creating quality care jobs that cannot be outsourced or automated. You can't replace those jobs with robots. It would also allow us to have dedicated funding for LTSS in a socially sustainable way and would not be competing with other budgetary priorities. Somewhat surprisingly, such a program would also provide support to the private insurance market. It could significantly boost the industry as public awareness increases dramatically. And think about, for example, today, how the private insurance industry wraps around Medicare coverage with Medigap. It would be the same thing here. You could have a private industry wrap around the public coverages. Next slide. So there are, as states consider these types of programs, there are a number of key decision points. For example, who is the eligible population? Would a program include people who are currently disabled? Maybe would it include those under 65, those who pay in like Social Security for a certain amount of time? All of these decisions have implications for specific program designs, options for how the program is to be financed, and also how much public support you may be able to garner for such a program. There's the timing and duration of coverage. You could imagine that a program pays benefits as soon as somebody becomes disabled, and maybe they pay for a year. That's what's happening in Washington State, for example. Or a catastrophic protection program that benefits only begin after somebody has been disabled for a certain amount of time, but then pays benefits for an extended period. Or comprehensive coverage, where you pay as soon as somebody gets disabled for their entire life. Again, this has implications for program costs and so on. The program financing issues to consider. The key issue here is, what is the source that makes the most sense for a state, recognizing that there are trade-offs associated with various financing sources? And by what criteria do we make judgments about financing sources? So shown in this slide are some of the key evaluative yardsticks to help policymakers decide what makes the most sense for a state in terms of the way to pay for such a program. Next slide. So, universal family care. The key idea is that care needs occur over the life course, and that most of us face at least one or more of these issues as we age. As mentioned, gaps in our current care infrastructure make it very difficult for workers to juggle the needs to earn a living and to provide family care, or to provide care for family members. Similarly, people needing time off work to recover from an illness or injury, as well as those needing LTSS, face a patchwork of programs that frankly fall short. The status quo is costly, and those in need of care, family caregivers, and the economy as a whole. The purpose of universal family care is to move us away from an increasingly untenable status quo. Next slide. So what is the vision? The policy vision of universal family care is a new integrated social insurance program to support families in coping with the risk of needing to provide or receive care over the lifespan, to which everyone contributes and from which everyone is eligible to receive assistance should they need it. We may experience a variety of care needs at once. Sandwich caregivers, for example, those folks who are both raising children and caring for adult older parents. And these needs are not actually felt by people in isolation. Busy family caregivers need a streamlined system of supports to manage their care needs over the lifespan. Next slide. So what are the pillars of family care? Imagine a single pool of dollars to which you contribute and from which you can draw upon when care needs arise. What does this do? Number one, it reduces incredible bureaucratic complexity for families. And the idea is that it provides a one-stop shop and single access point to address family care needs. The rationale for such a universal approach is that these needs or risks that are being insured against are normal parts of social and biological life for everyone. They're not just for people who are poor or have low incomes, they're for everyone. Hence, the focus on universality. Next slide. The advantages of an integrated and universal approach are listed on this slide. But the basic idea is that the new holistic and comprehensive social insurance approach is designed to support families, both needing to provide and needing to receive care across generations. The goal, at the end of the day, what we're trying to accomplish by having a combined holistic program is to create both an affordable, integrated system to all families to replace the patchwork that Marcy and others have spoken about of means-tested programs. Now, if I were listening to me, I'd be saying, you know, this is pie in the sky. Something like this must cost a fortune. Could I have the next slide, please? As part of our study panel, we engaged an actuarial firm to begin to do some modeling, like how much would a program like this actually cost? Let me begin by saying these are ballpark estimates for some stylized general programs. And what you see here on the left are the early childhood, paid family leave, and here what was modeled was front-end long-term services and supports coverage. Going horizontally, you see the different tax bases on which a tax could be applied. So these are ballpark estimates. Based on these preliminary estimates, the contribution level required to fund benefits could, in most program designs, be around 1.5% of earnings for most workers, with a higher rate on individuals earning above $200,000. If we assumed a flat structure, it would be about 2%. What does this mean? It means a family with a median income of $61,000 would pay around $80 a month. But if this family needs a home health aide, the median cost over the course of a year can be $50,000. And if they need childcare, the average cost could be, for someone under 4, could be nearly $10,000. So what this shows, it demonstrates the financial power of leveraging an approach based on risk pooling and insurance. Last slide, please. Oh, there should be one more slide. If there's one missing, that's okay. There was a slide that talked about some of the benefits, bringing all the interests under a common umbrella. But I think I'm going to conclude with making the following observation. The key point that I would like to make is that leaving the status quo, care infrastructure intact, that is kind of doing nothing and bouncing along the way we are, could actually be the most economically and socially costly option available to policymakers. Our current arrangements leave workers and their families largely to fend for themselves when care needs arise. This has pernicious effects on child development, adult labor force participation, family economic security, health, and quality of life. For that reason, the costs of waiting are now exceeding the costs of taking action. And now is the time to do so. Thanks very much.
Thank you, Mark. We are going to move into a panel, and I appreciate everyone sending in their questions. Please do that after the panel. We will have a Q&A portion. There was a clarifying question that came in while you were speaking, Mark, and that is it correct that this universal model does not tie the amount of benefits you can draw to the amount paid in?
That is correct. Think about, think about the fact that you're paying a known and certain premium related to earnings and access to a pool of individual benefits under each of those three rubrics.
Thank you. All right, so now we're going to move to a panel discussion. And, as I was listening to everybody's comments and presentations, it seems very easy to be overwhelmed both by the complicated patchwork, and I think many of us think about our own experiences of trying to navigate that complicated patchwork that really doesn't work that well for us, and also stay grounded in our values and our vision for a Minnesota where everyone can age and live with independence and dignity. And then also reflecting on the interdependence between the folks receiving care and the folks providing that care, whether family members or workers. And when I think about the immensity of the challenge in front of us, I can't think of a better state, not just because I'm from Minnesota, but actually a better state than Minnesota to tackle this problem. And a big reason for that is because we have so many amazing leaders on the ground here, like Representative Jen Schultz and the three folks we're going to hear from right now, who have been leading the charge on solving these problems and imagining what a better future can look like. So I'm excited for this conversation with folks here in Minnesota. So on our panel today, we have Nikki Villavicencio. She is the acting chair of the Minnesota Council on Disability, representing Region 11. That's Ramsey County. In St. Paul is in there. She's a former chair and member of the Maplewood Parks and Rec Commission and a member of the North End Task Force and a recipient of the Political Courage Award. And if any of you know Nikki, you know she is incredibly courageous and deserving of that award from the Women's Candidate Development Coalition. Also, Don Simonson, the Executive Director of the Metropolitan Area Agency on Aging, and the President of Innovations for Aging, LLC, and Deborah Fitzpatrick, the Director of Policy and Legislative Affairs for the Children's Defense Fund, Minnesota. And so we'll have a quick discussion with these panelists and also open up to Q&A that comes in for everyone who's spoken today. So first, the first question to the panel is, how could an integrated universal framework alter how people currently receive care services? And let's start with Deb.
Well, thanks again for hosting this. I just want to say I'm a huge fan of the Academy of Social Insurance's work in this area. I have the full 300-page report with many dog years and many underlinings, and it's been a huge help and a huge resource for me as I've thought about how we can move ahead as a state. I, before coming to the Children's Defense Fund, worked at the University of Minnesota at a public policy research center focused on gender equity, and have for the past 5-6 years been a leader on Minnesota's effort to pass paid family and medical leave in the state. And now working very much in the early childhood care and education space with Children's Defense Fund. I have been really looking at those two areas, but also really understanding how the elder care for folks with disabilities and others in our state all intersects, as has been talked about quite a lot today. I thought it might be helpful just to set the stage a little bit within Minnesota on some of the things that Marcy talked about in particular. Just to kind of give a flavor for why I think this state is particularly in need of advancing this approach and again, just some of the specifics. So Minnesota does have one of the highest workforce participation rates in the country for women with children under 6. And in many of our rural communities, those rates are the very and women, I think one of the things that we've seen as the COVID-19 pandemic has unfolded is that women, and particularly women of color, are disproportionately represented among essential workers during this pandemic. So they are the ones still working on the front lines. They're the ones that are in jobs that cannot be done at home, that must be done out in the community, incurring great risk, but also trying to manage the extra burden of care, whether it's, again, taking care of their own children, their school-age children, dealing with the health consequences and safety issues around COVID. So I think that's really important to acknowledge. I think it's also really important to remember that Minnesota has some of the worst economic disparities for Black, Brown, and Indigenous families. And a lot of those disparities are rooted in the issues that we've been talking about today. Minnesota has been a leader in advancing unpaid leave provisions for our state. We have protections for at least pregnant workers and new parents down to 20 employees, which picks up about 20% extra workers in the state, but that does not cover other types of care. And of course, it is unpaid. And we know that paid leave access in Minnesota, as in other places, is less accessible for families of color, Indigenous families, but also in Minnesota, our rural families have less access to paid during leave. I wanted to say just a little bit about our ECE scene in the state of Minnesota. It is extra fractured. I think it's fair to say, with multiple programs, including childcare assistance, early learning scholarships, voluntary pre-K, Head Start. And of course, all of those programs are underfunded and only serve a fraction of the families that are eligible due to funding. We also have huge shortages across the state, even before COVID-19, shortages in rural areas of our state, shortages in culturally responsive care and non-standard hour care. Again, many of those programs, as Marcy mentioned, are focused on low-income children. And we had severe cuts in all of these types of programs in the last recession and have not recovered, which I think is important to think about as we move into a new recession. So I do think it's really important that, across the country and including in Minnesota, we give a lot of lip service to care, but it really is stigmatized in our economic system, whether you're a caregiver or a care recipient, whether you're paid or unpaid. A lot of shame associated with not being able to manage care on your own as a family or needing care. A lot of negative assumptions are made about workers with care responsibilities. Rep. Schultz mentioned workers sneaking away to care for a family member, and that's how it is. I mean, we do not support care in our economy in many, many ways. So I do think this universal family care social insurance approach moves us away from a lot of these problems in a significant way. I think a system that's perceived as an earned benefit where everyone contributes and everyone potentially benefits is key to changing the way care operates in our culture. It would begin to address some of the systemic racism and sexism that is inherent in the way we think about care. As I mentioned earlier, paid and unpaid caregiving plays an important role in our state's health and economic racial disparities. So I'm going to stop there and let the others say something and come back to more later in the conversation.
Thanks, Deb. It's a great kickoff. Let's go to Nikki next. Nikki, the question was, how could an integrated universal framework alter how people currently receive care services in our state?
Sure, thanks. A lot of the work that I have done was directly, obviously, because I've been affected by it first and foremost. But, it really didn't spark a passion for me until I became a mother myself. And so a lot of the care work that I've worked on was through helping unionize home care workers. in Minnesota. And, through that work, it really parallels with the idea of the universal family care, because, it's all about taking the most marginalized people of our community. And they are on the same page as I am, as a person with a disability. I live below the poverty level, and increasing wages and giving training. We've been able to give paid training in our union, and I've been sitting on the training committee for since it started for the union. And the thing that why I bring that up so much is because it is the single, well, not the single factor, but definitely the major factor that I have seen that gives professionalism and legitimizes the job. Because if we can train folks and they have a skill, they're a labor worker with skills, then the way that I see it is the government cannot refuse to see that they need to be paid, and they need to be paid well. And so a lot of my comments I will make in the next questions too. So if the next person wants to speak, go ahead.
Thanks, Nikki. Want to go, Dawn?
Sure, thanks. Thanks, Eliane. Thanks, everyone. Just reflecting on your question about the how. So the question is, how could an integrated universal framework alter how people currently receive care services? So where my head goes first to this question and a potential answer is that, if we assumed that universal family care had a really primary significant benefit, and I'm speaking from the lens of services for older adults, that a primary significant benefit then would lead us to the creation or refinement of systems of information and access for older adults and their families, so that we wouldn't have certain access points for certain funding streams. So we would see a much less siloed system of information and access that would then lead to people learning about care and being connected to care. So I think there are some assumptions relative to what a financial benefit might bring, related to then the aligned systems that help people learn about and receive care.
Thank you. So we have 2 more prepared questions, and then I'm seeing a lot of questions coming in, so please send them in. Some of the remarks that I'm sure folks have already planned will answer some of the questions that are coming in, and also some that will go to a broader Q&A section with all the speakers from today. So our next question is, how would this affect different groups of people that need care services, including everybody, but including older individuals, people with disabilities, and families in Minnesota? I've got multiple windows open. I don't have the double screen set up yet, so my apologies as I scramble to find the right window. So we'll start this question with Nikki. And again, the question is, how would this affect different groups of people that need care services in our state?
Thank you. Yeah, so I guess I'll start out by saying, how could it not? I was excited about this question because, as I said before, the way that I am so excited about the idea of the universal family care idea is that it is universality. So for those of you who don't know me, I use my feet for everything. I take care of my daughter with my feet. I write with my feet. I do all my activities of daily living with my feet. And so when I first had my daughter, we were a multi-generational family. I had my mother-in-law who lived with me, and my partner who also is disabled. And so I really was able to see how the complexities and challenges around trying to navigate all the different types of care. Like it's like many of the presenters have said, it's a patchwork, and it is very faulty at best. And the time that it takes to, I think one of the presenters said, you know, knock on every door. It truly is. It takes like a whole full-time job just to figure out how to go through every type of program. And you know, and then, you know, as I you know, advocated more and more on my own behalf, and then others behalves, I you know, understood that the policies are so like locked in on not providing a care that really surrounds the person and their family. So, you know, a lot of times in these conversations, we talk about elders, we talk about families, and then we talk about people with disabilities, but really they're all of the same. So my partner and I drafted legislation at the state capitol around trying to provide care for parents with disabilities, because as it is right now, if you have a disability and you have care in your home, your care workers are not allowed to do any work that has to do with anything with your daughter. And it goes to the very details of handing children a plate or doing laundry that includes that. And so you can imagine how challenging that would be to try to you know, raise a family and deal with all those complicated policies that really go against how any family operates, you know. And so really that showed me that our policies, when we create the universal family care, is it needs to be centered around the most marginalized folks, because you know, I'm not the only family that has people with disabilities and needs care and provides care. You know, there's a lot of care that I provide for my partner and my partner provides for me, but because we receive care, we are unable to get paid for that care. You know, and a lot of the energy and the time that I have done has surrounded by trying to care for my family and do the work that I do. So when we unionized the home care workers in Minnesota, my daughter was 6 months old, and we had her in tow at the Capitol testifying. And she's been to many rallies. She's gone to everything that I've done in my life professionally, which is such a great blessing, but is not very practical for most families at all. And so, and part of the reason why is because as a person with a disability that receives Social Security, I am not eligible for child care assistance. So I was never able to use any child care assistance. Our daughter did go to Head Start, which is a wonderful program that a lot of actually families with disabilities use, because like for instance, my situation growing up, my mother was an unmarried young mother, and she was unable to work until I was about 5 years old, because there was no childcare that would take somebody with my disability. So as you can see, the cost of not doing universal family care is like generational. Not only is it not, you know, or is our current system not centered around the most marginalized people, but we are generationally oppressing people, and the cost is just immense. So you know, and then also too, I just wanted to mention the fact of the idea of the universal family care is the ease of use. I mentioned that before about how time consuming it is, but you know, most people are not trained or have any idea of how to operate in systems and navigate them. My partner is 14 years older than me, and so when I came into Minnesota, I was and we started a family together, I had a huge privilege because he had already managed many of those systems before I had even came through. But if I didn't have him to teach me that, I would have been so much far below where I am now. And so with that, I will hand it off to the next person.
Great. Deb, do you want to go next, and then Dawn, and then I'll start scooping in some of the questions we're getting into our to this next round of our conversation.
Sure, I'll be brief. I want to build on everything he said. I think that was right on target. I think the idea of the universal family care approach that I think is most powerful is that it really creates it has the potential, again, well designed. I think the devil is really in the details in many of these things, so that's really important to acknowledge, but has the potential to support meaningful choices for all kinds of families, right? And I think of the relationship between paid and unpaid care, for example, which is a powerful piece of this, right? Whether it is that you want to employ somebody to help you with your care needs, or you want to do them yourself, that people at all places in the economic scale and with all different kinds of life circumstances have the ability to do that. I think it's really, really imperative that we build these programs with inclusive family definitions so that we are able to make sure that we have all the care we need. If a neighbor wants to provide care, go for it. We need every caregiver we can have, and there are a lot of different ways to think about family. So I think about, again, a well-designed program with an expansive, culturally competent kind of approach to thinking about how we think about family would really give families choices as well as support in terms of navigating choices. Because choices, when you have 100 different kinds of coffee to choose from, sometimes that can be overwhelming. But it also improves our quality of life in some important ways. So I think balancing choices for families as well as support.
This is Dawn. I'll just jump right in. For me, I believe that individuals and families will gain peace of mind. And in an uncertain world that seems to have become more uncertain every day, that would be a tremendous gift. I think Mark and others have so well articulated benefits related to ability of caregivers to remain in the workplace, reduced risk in terms of financial spend for families, improved quality of care, et cetera. So I won't belabor that point. I might though raise two questions that perhaps we can address as we go forward, and one might be as we think about the potential premium for people who live at the margins. How do we think about $40 a month per worker? It seems obviously a question for more conversation. And then speaking particularly from an area agency on aging perspective, and the fact that so many long-term services and supports are delivered by volunteer-based organizations, and they're not very professionalized. So, what does that mean for providers? We want to be certain that we keep our networks of organizations strong, and that we don't do any harm related to really important, locally known, well-trusted programs that provide the daily in-home supports for people with functional disabilities. So I'll end there.
Thank you. So next question, I'm going to sort of weave together a couple of threads that have come in, and then there are a couple, I like this devil in the detail framework, devil in the detail questions that we'll get to after this next sort of broader landscape one. So, there's a question coming in, and there's been a lot, all of you have commented on both paid and unpaid care. For paid care, a real quality standard job metric around that. And, that also gets me thinking about my own experience with programs, just like paid family medical leave, but also any large social insurance program, is that, you know, the stories we're all telling are the stories we all live. And so very viscerally, every person in Minnesota knows we need a solution like this. And in my experience, it's less convincing people we need it and more convincing people that we can fund it, that we can raise the revenue to fund these types of programs, and that government can be a really important vehicle to deliver this sort of comprehensive, integrated, interdependent care that our families so desperately need. So I'd love just to open up reflections from any of the panelists around, you know, what is it going to take to build the public and political will to enact a program like universal family care, to fund it, and to make sure that the folks who are working in it have really good paying jobs? I know it's a big question, but feel free to tackle any sort of piece of that in your response. And maybe we'll start with Deb. We start with Dawn, go to Deb and Nikki, and then we'll get into some of the technical questions.
I would say that really thinking about, again, stakeholders that might not be in tune with the conversation related to long-term services and supports. And again, the network I know best, those you know, hundreds literally of nonprofit community-based organizations that may not be thinking about universal family care and what that might mean for them and mean for the people they serve, and really starting to think about including them in conversations about the concept and activating their advocacy and activating the voices of the older adults and family caregivers they serve.
So I think, first of all, just getting a lot more sophisticated about articulating the cost of doing nothing. You know, Mark talked a little bit about the impact on the Medicaid system. You know, we know that paid family medical leave also has the potential to save Medicaid costs. So I think we all know that there's a cost for the current system. It's just not as clear as the 2% payroll tax. And so I think we do have to get clearer about, you know, the incredible costs of doing nothing. In the early childhood space, we know investing $1 saves 10 down the road. You know, I think, again, getting really clear about how those things are interconnected. And then, I mean, again, the universal family care idea of bringing together these silos, I think, just has to happen. We have to get away from fighting amongst ourselves for a small piece of the pie, and build the pie together, and recognize our intergenerational independence in this space, interdependence in this space. And that's what's powerful about this approach to me, is that, you know, we don't leave anybody behind, but it also builds a very powerful coalition of people across the lifespan.
Yeah, Nikki here again. And, you know, I would just say that we need to have really kind of bold ideas about, you know, looking at in our economies, who's the one, you know, especially in the situation that we're in with the pandemic, and who's the one still making billions of dollars, and then who is not. And I think we need to just tax the corporations. And I agree with everything that the last panelist just said around, you know, being, you know, I feel like as a disability rights advocate, I've always been telling legislators that it costs less to do, you know, home care, for instance, than institutional care. But I mean, sometimes I don't know if that is, if it matters how much we tell them. But yeah, so those are my comments. Thank you.
Thanks, Nikki. I know Mark and Marcy are back with us, and I'll pose a couple of the technical questions to the two of you to field, and I know probably others on the panel can field them as well. So a couple questions. So One that came in was an ask, I think this came in, Mark, when you were speaking, and asked to speak a bit more on the one-stop shop and the types of administrative structures needed for universal family care. And then another technical question is sort of connected to that is what mechanisms would exist in the universal social insurance scheme, that is a tongue twister, to control prices. Primarily and prices of services that will primarily be provided by a network of private care providers and companies. And there's a lot of talk, or some talk already during this conversation around the need for public-private partnerships. So a little bit more reflections on the details. Maybe we'll start with Mark and then go to Marcy, and we'll have maybe a few minutes for like 30-second closing remarks if folks want to start thinking about that.
Sure, thanks very much. So I'll be brief. The first question related to administrative structures. So a lot of it will depend on what currently exists in the state. But first of all, there are two pieces to thinking about this. One is the collection of premiums. So there may already be mechanisms. You could build, the state collects unemployment, for example, payments. If states have paid family leave, they've already built on an existing structure. So on the premium side, you could imagine, I mean, the best thing is to try and take advantage of infrastructure that already exists so you don't have to make major investments. On the benefit side, we have whole systems of eligibility already in place. Think about Medicaid eligibility. You may have to change that as it relates to LTSS, however the benefit triggers are defined. But for all of these programs, part of what the state is involved in is determining eligibility for different programs. So expertise does already exist, and we should not discount it. The second question had to do with, like, how do you control costs and prices? To my mind, this is what is really one of the strengths of this kind of an approach. You're talking really about an earned benefit, right? So we make actuarial projections for Social Security all the time. What's really impossible is making projections when a program is part of a general revenue stream and it's competing with other programs. And on an annual basis, you have a question in your mind. How much is going to be allocated? Are they going to change? Here, it's segmented. It's has its own revenue stream. And in terms of I'll just take LTSS as an example. I'm most familiar with that. There are private companies right now that have nurse networks that will send people out to do eligibility assessments. Medicaid does eligibility assessments. And one of the things we talked about in the report is, in terms of implementation, building in upfront a function for a 2 to 3 year review to make sure that the premiums that are coming in are in line with the benefits that are promised by the program. So there are ways. This is a technical issue that can certainly be overcome. Taking it out of the general revenue stream removes a lot of the politics involved. And I think for this, that's a good thing.
Can I just add a Minnesota perspective on that real quick? I do think we're lucky in Minnesota that our UI system, actually a tiny silver lining of the COVID-19, that our UI system has performed quite well and has done many, many things in the last 3 months that they said would take 2 or 3 years and tens of millions of dollars to do in order to deliver paid family and medical leave, for example. So I do think in this moment, we're seeing systems adapt when they have to quickly, which gives us a roadmap. And our system in particular has done a fairly good job of that.
Picking up what Deborah said, I think that's great, because I was actually looking at Michigan and Florida, and their UI systems haven't been as successful, and so families are suffering. And so that is, part of this is it's creating a system in which there are fewer hurdles and fewer costs for families to get in with you point them in one direction, and that one direction will take them to getting their care needs reimbursed rather than going to multiple systems. Sounds like Minnesota must have a relatively healthy UI system to come out of this pandemic, and it's operating fine, because that hasn't been the case across most US states. But to add on to that, in addition to the reasons why this is so critically important, aside from the funding and it being taken away from general revenue sources, is I think we have some good examples of this happening and it not being as scary as folks think it will be, right? Because we always kind of go into these proposals for major programs. We want to have ambition, and then that ambition gets thwarted when it says, oh, well, it can't be done. But the first state, Washington, just implemented their paid family leave program, and they don't have a temporary disability insurance system. And so when paid family leave was first getting rolled out in the early 2000s, there's lots of talk among financial experts and researchers that they just weren't going to be able to handle it, or that it would be augmented by TDI. And it turned out that using TDI as the entry point was a great way to do it, that the system functioned fine. So now we're going to learn from Washington, who doesn't have TDI and is implementing paid medical and family leave. And so far, it seems to be going okay. And so, but they would be a good source of learning in terms of learning by having, creating this new program that was separate from TDI, therefore didn't already have this existing infrastructure. Well, let's go learn from them. How did they do it? How did they make it successful? And I'm guessing that they'll give us some good information on that and we can translate it. So I'm not as concerned, I guess. I would expect with any new major US provision, a social insurance or means tested, that there would be a year of learning curves to get it straightened out. And so I think that the bigger question is making sure folks are in place who can guide us through those transitions and make sure that the kinks are worked out and come up with real-time solutions for making the system easy to use, not only for families applying, but also for the folks who are distributing those benefits as well.
So I will just say, we took our UI director to Washington State last year.
Yay.
Thanks to Family Values at Work and others that are trying to bring people together across states. So it's been very, very, very helpful. I totally agree, Marcy.
All right. Well, we are a little bit over time, so I'm going to wrap us on this final note. And it's a great note to end on, which is both a lot of clarity that we can and should and must build a new system, and there's lots to learn together and from other places as we continue to figure this out and make really big changes here in Minnesota. And with that, I'll pass it to Bill to close us out.
Well, thank you. I didn't want this to end. This has been very enlightening and inspiring. So my thanks to all of the speakers for contributing your insights. Thanks to all of those participants who submitted questions. And I want to thank the Ford Foundation for funding the Academy's Universal Family Care activities. You will all be receiving an email following this session with a link to a brief survey. Please take a moment to share your feedback. We thrive on feedback, and we make changes to all our programs based on feedback from participants like you. Our Academy will continue to provide opportunities to exchange ideas through virtual forums such as these. And as I mentioned earlier, if you have colleagues in California, Illinois, and Michigan, let them know we'll be hosting similar webinars, or perhaps if things change, we can get back to the real world in at least one state across the country this year. For more information, you can all let Bethany Cole, who's our lead policy analyst who's our research assistant on healthcare, and who's championing and coordinating our efforts in universal family care. You can let her know by email, bcole, B-C-O-L-E, @nasi.org. One thing I think we know is we're going to continue to face uncertainty and anxiety in the coming weeks and months. So let us keep all who have faced losses, especially in the tragedies that have affected Minnesota, let's keep all of them in our thoughts, and please stay safe and stay healthy. And thank you again for being part of this session. Bye-bye now.